Hi, good evening, everyone. I just want to take a minute to welcome everyone to our GATS in the virtual community. This month, we are honoring Alzheimer's Awareness Month and talking about how to keep your brain healthy and how participants are protected during research studies. This evening, we have the honor of having Dr. Jane Otato as our moderator and our guest speaker, Dr. Scott Turner. And I just want to go over some housekeeping items before we get started. We ask
I'm sorry, I don't have the slides up yet.
Okay. Yep. We're just gonna give a minute to Dr. Fishbein to put up our slides.
You could start talking with the housekeeping, but I just wanted to at least let you know.
Yeah, absolutely. I had them in front of me. So, but I just wanted to let everybody know that you are asked to please keep yourself muted during the presentation. However, we are trying to make tonight's presentation a little more interactive. So you are welcome to ask questions during the presentation. You can put them in the chat box or you can verbally ask the question during a pertinent time. But we do ask to please be mindful not to disclose your name or information that is too personal, as we are recording this session tonight, and we do disseminate this information through our different social media outlets as well as YouTube. Every link that we will be mentioning different websites and different places that you might be interested in visiting online. So we will be putting those links on the chat box so that you guys can access them via the chat box as well. And at the end of the presentation, there will be a survey link sent to you, and we ask everyone to please visit that survey and send us your opinions and suggestions. So like I said, thank you everyone for joining. And so I just want to also remind everyone that GATS is a presentation that we do every fourth Tuesday of the month, with the exception of next month. If you're interested in joining us next month, we will be hosting that on December the 14th. So it's the second week of December. And for those of you who are joining for the first time, GATS in the virtual community is a place where researchers and clinical research experts discuss the research studies in various health topics. So every month we have a different topic. And if you're interested in learning more about us, visit us on GATS community. And we will, like I said, be putting the link on the chat box. And we are also on Facebook on their GATS community. Just a super quick disclosure here, Dr. Jane Otato has no actual or potential conflict of interest to disclose in relation to this presentation. And Dr. Scott Turner receives research support from all the various entities listed here on this slide. And like I said, we are very happy to have Dr. Otato joining us this evening, and it's not the first time she's going to be moderating our session. So I just want to give a quick intro. Dr. Jane Otato is an interim director of regulatory ethics, knowledge and support, also known as REX, a module of GATS. She holds a doctorate in medical sociology and social demography, and she has a master's in international development and health. She completed a postdoctoral fellowship at the Center of Disease Control, and her research interest has been focused on minority health and health disparities relative to issues of availability and accessibility to healthcare services. And there's some additional information that she can share with us, but I'm going to go ahead and let her take on from here and introduce you to tonight's agenda.
All right. Good afternoon, everybody, and welcome to GATS in the community. We're glad to be here. Let's talk about it. What is GATS? Today, basically, Dr. Scott Turner will be talking on this month is National Alzheimer's Awareness Month. So Dr. Scott Turner later on will be talking on Alzheimer's and how to keep your aging brain healthy. And I will also talk about what are participants protected, how participants are protected in research. And to get started, what is GATS? GATS is a Georgetown Howard Center for Clinical Translational Science, and it's a partnership between medical institutions created to transform clinical research so that new treatments and cures and for diseases can be delivered to patients more effectively. Our goal is to really increase health research awareness to the community and to share with folks that help us do a clinical research. Those are the communities. So we support researchers who really conduct research that will have a high impact on in research. What is research? Research could be stated is health research is the process actually for testing new ideas and treatments to find out how to prevent, diagnose, and cure treat illnesses. What are the benefits of research? Researchers have been able to advance health, such as finding better treatment for cancer and diabetic. Some people take part in research to access new treatment for themselves. Others do it to improve the health of their family and friends. And many other people take part just to help in the research to cover new ways to improve health in the future for future participants. At the same time, there's a big growing recognition that within the Black community, and not only within the Black community, also within any racial and ethnic backgrounds, that its members need to be part of this clinical trial. They cannot be afford to be absent, because if you're absent, if they don't participate, then when the medications come out or treatment come out, you don't know how it's going to work in this population if they do not be part of the clinical trials. So we have to be included in there. So right now I'm going to introduce our guest speaker, Dr. Scott Turner. Dr. Turner is a vice chair and professor in the Department of Neurology and also director for the Memory Disorders Program at Georgetown University, Washington, D.C. He's a board certified psychiatrist in psychiatry and neurology. Dr. Turner research has focused on developing new treatments and biomarkers for neurodegenerative diseases for aging, particularly in mild cognitive impairment and dementia due to Alzheimer's disease. He directs numerous multi-center, randomized, placebo-controlled clinical trials and research studies. Today he's going to talk on Alzheimer's disease and how to keep your aging brain healthy. Welcome, Dr. Turner.
Thank you for the invitation. It's a pleasure to talk about Alzheimer's disease today. One of the most common questions that I get is, what can I do to avoid having to make a clinic appointment in your clinic? A lot of people don't necessarily want to go to a memory disorders clinic, and I can understand why. So we're going to get to some of the things that you can do to protect your brain health as you age and prevent cognitive decline with aging, which we call mild cognitive impairment. And then as it progresses, we call it dementia. So the good news is that everyone is living longer. And on this slide, this shows the life expectancies that are increasing across the world. There were always some countries that claimed that they never had Alzheimer's in their country. But as their life expectancies are getting up to the 60s and beyond, it seems like it's also occurring there. So it's affecting every country in the world as life expectancies increase. On the left half of this slide are the number of people who are reaching age 100 in Japan. And so you can see the increasing life expectancy there. And there's a very similar curve in the United States. So the good news is we're making progress with heart disease, cancer, other disorders, so that people are living longer. There's been a little bit of a hit from the opioid epidemic and then more recently from COVID. But in general, life expectancies are still increasing across the globe. On the next slide, so the good news is that we're having more years in our life, so we're getting more quantity of life. The bad news is that the longer you live, the more likely you're going to have a problem with dementia, and particularly Alzheimer's disease, which is the most common cause of dementia. Dementia is the more global term. There are many, many causes of dementia, but in advanced countries, the most common cause is Alzheimer's disease. So this slide shows you the increased prevalence of Alzheimer's disease with age. So it starts off in the 60s, 70s, and then increases, doubles every 5 to 10 years, so that by the time you're 85 plus, about 30% of Caucasians will have Alzheimer's. And it's about double this in Hispanic and African American populations. And we don't really understand why. This is one area where we need to do more research and try to understand why this is. There are environmental theories, there are genetic theories, but basically we're not sure why exactly the Alzheimer prevalence should be higher in African Americans and Hispanics compared to Asians and Caucasians. So the good news is we're living longer. The bad news is we're running into this more and more of this Alzheimer problem. And that's shown on the next slide. So in the green dots here are the number of people with Alzheimer's in the United States. So you can see we currently have about 5 million to 6 million people with Alzheimer's, diagnosed with Alzheimer's in the United States. And unfortunately, this is projected to increase, as you see in the green line here on this slide, up to about 12 to 13 million by age 2050. And on the blue is the projected cost of the Alzheimer epidemic, or what we call the silver tsunami. A lot of the costs are going to Medicare and Medicaid for diagnosis and treatment, but a lot of the costs fall to the families, particularly, for example, nursing home placement, memory placement, living situations that are outside the home, or hiring home help. A lot of the costs fall to the family to care for their loved one with Alzheimer's disease. The red line at the bottom is the investment in research in Alzheimer's disease. The good news is there has been a big increase in investment in research to try to find new treatments that we're going to talk about a little bit later. So on the next slide, people come to our clinic with memory problems, mostly older people complaining of memory issues. Some come sooner than others. Some come in what we call the worried well stage, where they're perfectly normal and we do all our evaluation and we say it's just normal aging, everything is fine. We can't find a diagnosis. We call these individuals worried well. Others come in the very early stages of memory loss, where they're bothered by their memory decline, and others are starting to notice this. They're repeating things, forgetting things. And then others come in where the dementia is more advanced, and even some come in where the behavior problems are out of control from the dementia. They want the behavior problems managed. So when we see someone in clinic, our first job is to make a diagnosis. So as I mentioned, dementia is the global term, but Alzheimer's disease is the most common cause of dementia in the United States. Probably the second most common diagnosis in our clinic is Lewy body dementia, which has some features of Parkinson's associated with it, such as slowness and stiffness, sometimes visual hallucinations, seeing things that aren't there, usually animals or people. Sometimes with fluctuations, like very marked fluctuations, like someone can be pretty with it one day and then very demented the next day, and then fluctuate back and forth. And a lot of the patients start off with Parkinson's disease, which is the tremor and the slowness and the stiffness. And these people also tend to fall a lot. So this can be distinguished from Alzheimer's disease and has a very different pathology and treatment. The next most common cause of dementia is frontotemporal dementia. This presents with behavioral problems, sort of disinhibition, sort of lack of any social inhibitions, doing things that are socially inappropriate. Some people present more with a language problem, difficulty with producing speech, for example. Other causes, multiple strokes. Approximately half of the people who have HIV infection will develop some memory problems. And this is called HAND, or HIV-associated neurocognitive decline. Other causes, depression, drugs which may be impairing memory. Someone can be an alcoholic and become demented from alcoholism. Chronic traumatic encephalopathy, which the football players are being increasingly diagnosed with lately. Hypothyroidism, B12 deficiency, other rare causes. And at the very bottom of this list is neurosyphilis, which means syphilis has been untreated and is infecting the brain. And 100 years ago, this was the #1 cause of dementia. So there used to be nursing homes with people with dementia from neurosyphilis. But of course, now we hardly ever see dementia due to neurosyphilis, and this has been replaced by dementia due to Alzheimer's disease. So on the next slide, the risk factors, as I mentioned, was #1 is aging. So all you have to do is age, and you increase your risk for Alzheimer's disease. And we talked about how the risk increases with age. The second most common or most important risk factor is having a family history of dementia or Alzheimer's disease. And there are some genes that increase your risk. There are about 100 families in the world that have a very rare mutation that causes early onset Alzheimer's, familial Alzheimer's, and these pedigrees have the onset in the ages of the 20s, 30s, and 40s, and half of the pedigree has early onset Alzheimer's, so they sort of stand out from all the millions with the late onset sporadic form of Alzheimer's. They're pretty rare, but these mutations have taught us a lot about what we think causes Alzheimer's. The more important risk factor is the ApoE gene. And so we have 2 copies of the ApoE gene, one from our mother, one from our father. And about 25% of the US population has the high risk variant, which is the ApoE4 variant, which increases your risk of Alzheimer's. If you have 1 copy of ApoE4, you're about 3 times the risk of people who don't have this variant. And if you have 2 copies of ApoE4, which is pretty rare, you have about 8 times the risk of getting Alzheimer's disease. So this is probably the most important genetic risk factor for Alzheimer's and sporadic Alzheimer's, which is what the majority of people have present in older age. Down syndrome, individuals get Alzheimer's in their 40s and 50s. And as we already talked about, African American and Hispanic have higher risk than Caucasian and Asian. And this may be due to genetics or maybe environmental or probably some combination of both. So in yellow are the big 2 risk factors, but there are lots of other minor risk factors. You'll note that number 1 and number 2, you can't really do much about. Obviously you can't stop time and you can't choose your parents. But there are lots of other risk factors on this list that you can do something about. And these are what we call the modifiable risk factors. Diabetes is probably the most important on this list, which increases with obesity and poor diet. Metabolic syndrome, hypertension, also risk factors. Having a traumatic brain injury with loss of consciousness any time during your life increases risk. Smoking, having a history of a stroke, lower education and occupational level, air pollution exposure, and females may have a slightly higher risk than males. So the white ones are the modifiable risk factors. So this slide is probably the most important one tonight. And these are all the things that you can do to try to not have to make an appointment in the memory disorders clinic. And this is sort of listed from the best evidence to the least evidence. So probably the most important on this list is getting exercise and physical activity, at least 3 to 5 times a week, at least 30 minutes per session, enough exercise, hopefully to get a little bit of short of breath or break a sweat. And there's lots of evidence to show that if you do everything on this list, you could probably delay or prevent dementia and Alzheimer's disease by at least 5 to 10 years. Next most important is keeping ideal body weight throughout your life, eating a Mediterranean diet, which is mostly a plant-based diet, with fruits and vegetables, very little in the way of processed foods, sugar and red meats, no solid fats. If you want to use a fat, use liquid fat such as olive oil. And having more education is also protective, limiting alcohol consumption, keeping mentally active, socially active, with social connections, avoiding traumatic brain injuries. For younger people, this means things like using seat belts and helmets for sports, and for older people, it's usually fall prevention strategies. Getting good quality, adequate sleep, no smoking, minimizing stress, avoiding air pollution if this is at all possible. If you need glasses, you get glasses and use them. And if you need hearing aids, you get hearing aids and you use them, because you don't want to deprive any information getting into your brain. So you don't want sensory deprivation. You want to make sure you keep your brain stimulated, and then if you need glasses and hearing aids to do that, then you get them and use them. Treat hypertension, diabetes, cholesterol, sleep apnea, depression with your healthcare provider that you're seeing on a routine basis. And if memory problems do develop, then seek an evaluation, get tested for thyroid disorders, vitamin B12 deficiency, and maybe syphilis and HIV with your healthcare provider. So as I said, do all those things and you can try to avoid or prevent having an appointment in the memory disorders clinic. But even if you do all these things, you're also going to live longer. And as we mentioned, aging is the #1 risk factor. So on the next slide, you can still develop mild cognitive impairment and dementia. Even if you do all those things, you just develop them later or when you're older. And this is what we call mild cognitive impairment, where you begin to fall off from the pack and your memory gets worse than we would expect for normal aging. And the memory starts to impair your abilities to do things, you repeat things, you forget things, you lose things. And on formal testing, you develop some memory problems, which is, as I mentioned, is worse than expected for age and education. And then the MCI usually lasts 1 to 2 or 3 years, and then you progress to dementia. And dementia means that you're having memory and cognitive problems, but now they're also beginning to impact on your ability to function in your daily life. So you may have difficulty driving, you may have difficulty being in charge of your daily finances, you may have difficulty being in charge of your own daily medications, and you just start to have more and more difficulties and need supervision on what we call those complex activities of daily living. And then as the dementia progresses over several years, each year slightly worse than before, you eventually need help with dressing, bathing, grooming, walking, transfers, toileting, eating, what we call the basic activities of daily living. So the dementia goes from mild to moderate to severe. Next slide. We do have medications that are approved for Alzheimer's disease, and you can see the year of approval here. You can see that the last new drug until this year was approved in 2003. 3 of these drugs are what we call cholinesterase inhibitors. They sort of support the neurotransmitter acetylcholine, which you need in your brain to make new memories. One of them sort of protects neurons from dying in the Alzheimer process. But there's been no new drug approved until this year since 2003. So it's been a very difficult road in trying to discover and find new medications, more effective medications. But on the next slide, what we have done, where we've made a lot of progress, is in what we call biomarkers of the disease. So these are features of the disease that help us with diagnosis, that help us with predictions of who is going to develop mild cognitive impairment and Alzheimer's disease. So at the bottom line there, you can see the MCI. This is when the memory goes downhill, and then you cross into dementia, and this is when the memory and cognitive function begins to interfere with your daily life. But these other lines are what we call biomarkers of the disease. And the one on the left is looking at amyloid in the brain. So amyloid is an abnormal protein that accumulates in the brain, is neurotoxic. And you can see that the amyloid is accumulating in the brain for a long, long time, 10 to 20 years, before you even develop any memory problems, where we cross into the MCI categories. So these development of these biomarkers is now not only helping with diagnosis, but helping us to predict who is going to develop Alzheimer's disease in coming years, and allowing us for the first time to set up prevention trials. So we can identify people who are still cognitively normal, and this is what we call the preclinical stage of Alzheimer's disease, and start and enroll them in prevention trials with anti-amyloid antibodies, for example. So the biomarkers have really come a long way in the last 10 to 20 years, whereas the treatments have not in particular, but we think that the development of these biomarkers is leading us and helping us to figure out, what these new treatments might be, and what strategies we can use, and what effective strategies we can use to get better treatments. So the next slide, these are some of the biomarkers that have been developed, and these are PET scans of the brain. So the 4 PET scans on the left are normal individuals. Their memory and cognition is completely normal. And the 2 on the right are a person with Alzheimer's disease. And these are PET scans looking at how much amyloid is in the brain and how much tangle or tau pathology is in the brain. So the person on the right has Alzheimer's disease, and the 2 people on the left are normal. But you can see these changes are starting in the brain, and these are the biomarkers from the imaging PET studies. We can begin to see these changes 10 to 20 years before the onset of dementia. And we're sort of having an internal debate in our field. When exactly does Alzheimer's start? Does it really start when you get memory problems, such as the person on the right? Or does Alzheimer's start with the two people on the left, when you begin to see all these pathologies accumulating in the brain, even though they're still cognitively intact? And you can think about, for example, breast cancer. Does breast cancer start when you have symptoms of breast cancer, when you have weight loss and bone pain from metastases and things like that? Or does breast cancer start when there are a few cells, they're cancerous cells, but they're asymptomatic. They're not causing any symptoms whatsoever. So, it's kind of a debate about when these diseases really start. Right now, we're still calling Alzheimer's disease when you develop memory problems. But there's been sort of a discussion and a debate about whether we should call the two people on the left Alzheimer's disease as well, because they're beginning to show all of these abnormal pathologies in the brain. And you can see the person on the left has the abnormal pathologies starting in the hippocampus, or what we call the medial temporal lobe or hippocampus of the brain. This is the part of the brain that you need to make a new memory. So someone with Alzheimer's disease, their old memories are usually pretty good and they're intact for a long time. But the most difficult thing to do for an Alzheimer patient is to make a new memory. So for example, if you ask them, what did I have for breakfast this morning? Or you give them a list of words to remember, they just cannot do it. But if you ask them something from 30 or 40 years ago, they would be able to remember that, because that's an old memory. So making a new memory is the hardest thing for an Alzheimer patient to do. So next slide. As I mentioned, we've developed these imaging biomarkers to tell us who has Alzheimer's, who is going to get Alzheimer's. And this technology started with the glucose PET scan in 1980, MRI of the brain, amyloid PET, tau PET. These are the imaging biomarkers. And then the next generation of biomarkers was looking at proteins in spinal fluid from a lumbar puncture. So this is looking at amyloid and tau and neurofilament light, different proteins in the spinal fluid indicating these neurodegenerative diseases. And then more recently, there's been a lot of work in the blood test for Alzheimer's. This is something that we've always been looking for because the PET scans are expensive and the cerebrospinal fluid proteins are invasive, meaning that you have to get a spinal tap that nobody really wants to get. So we're trying to develop these blood biomarkers, and this has been really an incredible development in the last few years, that we're getting really good at being able to diagnose Alzheimer's and predict who's going to get Alzheimer's from a blood protein test, such as amyloid ratios, neurofilament light, phospho-tau, these different proteins in the blood that we can now measure to help us, again, with diagnosis and prediction and prognosis and who's going to get Alzheimer's disease. So they're not quite as good yet as the PET and the spinal fluid markers, but they're getting pretty good, and they're getting good enough that we can use them for screening. There's a lot of cancer screens that happen, but we're not really screening for dementias. And now that these blood biomarkers are becoming available, we can start doing screenings for dementia and Alzheimer's disease. So next slide, there's been several trends in Alzheimer's disease recently. One is this new technology of these biomarkers that have been developed. Some of them are imaging biomarkers using a PET scan, these cerebrospinal fluid proteins that we're measuring, and then more recently the blood proteins that we're measuring, the so-called blood test for Alzheimer's disease. We're shifting earlier in the Alzheimer's spectrum. Traditionally, we only diagnosed and treated people who have Alzheimer's disease when they get demented, but now we're focusing more and more in the mild cognitive impairment stage, which is the prodromal Alzheimer's. And now we're even focusing more and more on the preclinical stage, which is when these pathologies are starting to develop, but people are still cognitively intact, cognitively normal, and starting to do prevention trials for these individuals. When we do these clinical trials, our typical enrollment population is usually 90% Caucasian. And as I mentioned, African Americans and Hispanics have a higher prevalence of Alzheimer's disease. So we really need to increase our diversity. We've been trying to think of strategies to increase the diversity of the study population, because we don't just want to know if a medication works in Caucasians, we want to know if a medication works for everyone. And, is it effective, and does it have side effects in everyone, or, not just Caucasian? So we really want everyone to come forward and partner with us in these clinical trials and increase the diversity in our study population. And another positive trend has been more and more NIH funding for dementias and Alzheimer's disease. And this has been very much needed because I think, finally society is realizing the impact of dementia and Alzheimer's disease is probably the one disease that has the largest unmet medical need as far as treatment in all of medicine, as far as I can tell. So it's been good that we've had more funding and interest and more research in trying to find new biomarkers and trying to find new treatments, more effective treatments for dementia and Alzheimer's disease. So next slide. So we have a memory disorders program at Georgetown, and we have several research studies that are underway. Some of these don't involve any drug treatment whatsoever. They're just trying to understand the disease process better and develop new biomarkers or validate existing biomarkers. And so these are the studies that are ongoing to try to look for new biomarkers. For example, we're collaborating with an investigator at Marymount University who is looking at language changes to help diagnose early Alzheimer's disease just from recordings of telephone conversations to see how language changes and can that predict who is going to develop MCI and Alzheimer's and use it for diagnosis as well. On the next slide, we also have trials that are testing new drug treatments. And you can see a lot of these new drug treatments are anti-amyloid antibodies. So because it's an antibody, you can't take it by mouth. It's a protein. It would be digested by your stomach. So we have to give it intravenously or subcutaneous injection. And so these are some of the antibodies that we are studying. And the one in the middle, aducanumab, was recently FDA approved in June of this year, but it's a very controversial approval, and we can talk about some of the controversy. We're not generally recommending it because the efficacy, the effectiveness is still being debated. There's no question it removes amyloid from the brain, but there is a question as to whether this actually makes the patient any better, or does it actually change the course of the dementia? And this is where the controversy is. It's also very expensive and not covered by Medicare or insurance, and it has a significant risk of side effect. So it can trigger a lot of inflammation in the brain, swelling and edema. And in one case, we just learned recently that there was a fatal side effect of swelling of the brain from this antibody. So there are other antibodies that are looking even more promising in the pipeline, and these are being studied at Georgetown and other places across the country. And some of these trials are closed to new volunteers, but some are open to new volunteers. And we're always looking for people in the early stage of Alzheimer's disease, mild Alzheimer's disease, or mild cognitive impairment, who would be interested in learning more about participating in a clinical trial. Our trials usually last 1 to 2 years, typically require a visit to the clinical research unit, which is part of the guts, for once a month for 1 to 2 years for the intravenous treatment or the subcutaneous injection. And so we're always looking for volunteers for clinical trials. And we estimate in our field that only about 1% or probably less than 1% of people with Alzheimer's participate in any research whatsoever. And so we really need to increase the numbers of people who join studies if we want to make progress faster. And on the next slide, as I mentioned, we've also launched prevention trials for Alzheimer's disease. So these are looking for older people generally who are cognitively normal, no memory problems. But for example, they may have a positive amyloid PET scan, or they have a lot of amyloid in their brain, indicating that they're on the track towards developing mild cognitive impairment and Alzheimer's disease. And we have 2 prevention trials underway looking at different anti-amyloid antibodies to see if they will be effective in preventing or delaying the onset of mild cognitive impairment and Alzheimer's disease. One of these is closed to enrollment, which is the first one, the A4 study, but the second one is looking for volunteers now. So people who are older, cognitively normal, may have a positive amyloid PET scan, could join this study of an anti-amyloid antibody or a placebo, of course, because all of our trials are placebo controlled. Usually 50% chance of placebo or less in our clinical trials. And we treat with this antibody or the placebo for some time to see if it affects the course of the disease and to see if this can prevent Alzheimer's disease. So the next slide, this is a website. This is an advertisement for a website that's available to anyone who's over 50. You can go to this website called aptwebstudy.org. It is a study, but it also offers you brain games and tracks your cognitive performance. So people who enjoy doing brain games and think that this may be effective in preventing cognitive decline, which it may be, can sign into this website every 3 months, do testing, and it's no cost, it's private, secure. And if it finds that your memory is declining over time, it will send you a message and say, you know, looks like your memory may be declining. You may want to be checked out by your, clinician or memory disorders clinic, or, and it's entirely optional, up to you, whatever you'd like to do, whether you want to be evaluated or not. So I would encourage anyone who's over 50 to just have a look at this website. It also has a lot of information, as some of what I've talked about tonight, on how to protect your brain health with aging and prevent memory loss with aging. So lots more information there on this website if you would like to join. It's an NIH funded website. So, and as I said, it's available to anyone over 50. So in the next slide, so I think I'm done, and I think, I don't know if we have time for questions now, or we want to do questions later.
I think we'll do them after this brief talk about protection in research, okay?
Okay.
And we do have questions in the chat.
Yep.
So you can review them. Thank you so much. And Jane, will you now take this part of the talk?
Sure.
Thank you. Dr. Hurtado, sorry.
Okay, here we go. So that's a great presentation, and you heard Dr. Turner saying that we need everybody from different racial and ethnic background to really participate in clinical trial, so folks can know how medication will work for them. If it's not tested in them, we will never know how it works on that population. So here we go. How are participants protected in research? So there's a lot of protection. So when you participate in clinical trial, these studies are usually vetted first. They're reviewed by the Institute Review Board, which makes sure that the research is safe and people who take part in this research are protected. So all research with the human must be approved before it gets started. And this group is called Institute Review Board, IRB, we call it. Next slide. The IRB reviews and make sure that the possible risk and benefits of research study have been carefully considered. What they actually do, they review to make sure that the risks are justifiable by anticipated benefits, if any, to the subjects or to the importance of the knowledge to be gained from this research, and that there is a fair selection of making sure folks who need to be included through the lifespan are included, whether age group, race and ethnicity, and different population, and that the informed consent is adequate. So the RB must go through, each RB must go through an approval process. The RB assure that the group meets all requirements for doing this kind of work. Next slide. Each RB have at least 5 members. The members could be researchers, physicians, people from outside medical field, but they have to have at least a local member from the local community. Ordinary person like us who doesn't know nothing, not physician or anything, but just need to understand the research from that level. Members of the RB, they are fully trained to make sure that they understand all the federal regulations, laws and local laws related to human research. Studies usually include they try to make sure they include diverse groups of people. Like Dr. Turner said, they need to participate to be able to know how the medication thing might work on them. They also must include children, women, diverse minority groups in research, and they must be sensitive to the interest of the diverse population. Next slide. The RB look at and review detailed written plan for each and every study. The research plan gives detail about the research. It tells why the research is important, why the participant being asked to participate, and this is called a protocol. So they make sure that it meets all the rules of FDA, if it's an FDA study or NIH study, all regulations are being met. They also check to make sure that everyone on the research team has the qualified training to do the research. Are they qualified to do this research? Do they have the training that they need to do research? So that's what RB does. The possible research that people might face in the study are looked at very closely because they're all about human protecting, human participating, human subjects participating in this research. If the risks are acceptable, like I said, the risks are justifiable by anticipated benefits, if any, to the subject or to the importance of the knowledge to be gained from this research. They make sure that researchers have taken adequate steps to protect participants. They also make sure researchers reduce any risk as much as possible. And this includes, of course, confidentiality, which is the data they're going to collect during the research, and the privacy of the people participating in the clinical trial. Next slide. The consent form is another written document that carefully checked by the RB. They make sure that the consent form matches the written research. The consent form must tell people everything that they'll be asked to do, why they start, what is the study, why is the study important, why it's been done, why am I being asked to participate in the study, and how am I be protected, what will happen with the procedures, who do I need to call when I need and have an emergency or I need more information. This is what goes in the informed consent. And the RB makes sure that all this is in there and their rights are protected as they participate in this clinical trial. Signing a consent form is only one step, but this gives you that you're agreeing to participate in the study. You've been given enough time to ask questions, and you understand what's going to be happening to you, procedures, how long each visit will take, how long you'll be in the study, procedures, risk, benefits, all that need. And you're given an opportunity to ask enough questions and be able to say, I do understand, and I'm ready to participate. Then you could sign it. And there should not be any pressure, and you should be allowed to drop out anytime you want in case you don't want to continue the study or after being enrolled the study without any penalties on your healthcare. Next slide. So research people is guided by 3 golden rules. The golden rules are that people are treated with dignity, respect, to do good, and to be fair. Even in the face of the fast-pacing research beat of COVID-19 and other diseases, RB will still make sure people are safe and all the rules and research are followed. Next slide. So let's talk about clinical research. We have several resources about clinical research. This website here was created for the community to provide ways to understand research terms that might be reported in the news, use research information to make personal health choices, and be informed about how people who take part in the research are protected. And you can also find other research studies going on. So I think the link will be included in the chart. Next slide. Here we go. Any questions that you may have for Dr. Turner or any other questions, please put in the chat box.
So
I can go through some of the questions in the chat box, if that's okay.
Yeah, that'd be great. Thank you.
So there's a question about, can you talk more on sleep and Alzheimer's disease? There's been some studies with the Alzheimer mouse models lately that sleep deprivation increases risk of Alzheimer's, and there's evidence that during sleep, at least in mice anyway, sleep sort of washes out the amyloid from the brain. Whether this is occurring in humans or not, we're not quite sure yet, but we certainly recommend getting good quality and adequate sleep. This may require good sleep hygiene as far as, not sleeping too much during the day, avoiding coffee and alcohol close to bedtime and things like that. And if medications are needed for sleep, then we also recommend medications for sleep. And as I mentioned, more education is protective against Alzheimer's disease. We're not quite sure what the mechanism is here. Perhaps it gives you more of a buffer when things start to go downhill as you age. But certainly the more education you have, then the lower the risk of Alzheimer's disease. Are the blood biomarkers at the local level? Yes, we're doing some blood testing in our clinic. We're measuring A-beta levels in blood, as well as determining the ApoE type from blood. So we're definitely doing some testing of the blood biomarkers at the local level. Other blood biomarkers are available to any clinician, but unfortunately, Medicare and other insurers are not covering these tests yet. This may change in the future, but right now getting coverage for PET scans and blood tests and these other biomarkers has been difficult with Medicare and insurers. They're still in the research stage, but we think this will change in coming years, particularly as we start to get more effective therapies that are approved. If we start to make diagnoses earlier and earlier, how do we protect patients from adverse outcomes of employers, insurers, et cetera? Well, if this is in the clinic, then obviously this is confidential information. You don't have to tell anyone. You don't have to tell your employer or your insurer. If it's research, it doesn't go into your medical chart at all. So, there are ways to prevent information from certainly getting to your employer or your insurer. You can also find out your own ApoE genotype from companies direct to public marketing like 23andMe will tell you your ApoE genotype. And this, of course, is entirely private between you and 23andMe. You don't have to tell anyone whatsoever about whether you have the risk gene. It's also illegal to discriminate based on genotype for medical insurance. So far, it doesn't cover other insurances like disability or long-term care. But for medical insurance, it's illegal to discriminate based on genetic information. So there are ways to keep information private from others. If you have a family history of dementia, even if you do everything listed, what are your chances of getting dementia? If you have a parent who has dementia or Alzheimer's disease, you're at least 2 to 3 times higher risk than people who do not have a parent with dementia or Alzheimer's disease. So this just reflects, some of this reflects the ApoE genotype that you inherit from your parents. But there are other genes that we still don't know yet and need to find out in more research. What age range does your research volunteers need to be? Our research, it depends on the study. Some start at age 50, some start at age 65, and sort of ranges in that area as far as the lower age limit. And then our upper age limit is usually around 85, although some studies go up to age 90. So that's kind of the age range that's typical for our clinical research and our clinical trials. Is there any research on oils other than olive oil? For some reason, olive oil always turns out to be the best, but basically any liquid oil, plant-based oil is better than any animal fat. And if liquid is better than solid and vegetable is better than animal. So there are other oils that may be just as good as olive oil, but for some reason, olive oil always turns out to be the one that's studied the most and turns out to be the best. What kind of symptomatic improvement would you hope to see in novel medicines that could be developed? So our new treatments, we hope would stop any further progression of cognitive decline, dementia and Alzheimer's disease. So the people who get the placebo, we know what sort of rate of decline to expect in people who are not treated. But the goal of the new treatments is to stop this from happening. So, so it stops it in the very early stage when you're still relatively functional, so you don't have any further decline. And then we go further back, and the next goal is to find people who are high risk and prevent any cognitive decline. So that's sort of the prevention studies that I talked about, is to use these biomarkers to identify people at the highest risk and then give them a treatment that would prevent them from ever getting mild cognitive impairment or dementia. So that's the goals of our treatment trials and our prevention trials. Do we know how exercise or why exercise lowers risk of dementia and Alzheimer's disease? Any particular exercise is better than other? We don't really know the mechanism yet fully, but I think part of the mechanism is that it prevents obesity and diabetes. And as I mentioned, being overweight, obese, diabetes, and then having hypertension and metabolic syndrome, all of those are risk factors for dementia and Alzheimer's disease. So one of the mechanisms may be just preventing you from getting overweight, obese, diabetic, hypertensive. But there may be more than that, and there may be growth factors that are stimulated that promote new neurons to be born in your brain, for example. So this is another area that's being investigated, including with exercising mice and other animal models of Alzheimer's disease. So we're trying to find the drug that mimics exercise so that you can just give the drug and not have to exercise. But so far, we've not discovered that yet.
That's one way to do it.
So unfortunately, you still have to exercise. And this is probably the best, the one thing that has the best evidence in preventing dementia and Alzheimer's disease. Any particular type of exercise better than the other? And the answer to this question is the one that you will do. is the best. So you find something that you enjoy doing. So whatever exercise you enjoy doing, it could be alone or it could be part of a team. So any exercise that you enjoy doing that you will continue into the future for the long term, for the long haul, and not just something that you do for a few days or a week or two. That's the exercise that is the best. And it has to be probably some combination of aerobic plus, resistance is the best combination. And the aerobic has to be vigorous enough to get your pulse elevated, to get you a little bit short of breath, maybe break a sweat. Some vigorous exercise 3 to 5 times a week, and then some resistance exercise as well. And as I mentioned, the best one is the one that you will do for the long haul. So whatever it is that you enjoy doing. And I know some people have difficulty because maybe arthritis of the knees or something. So you find something that you can do that's not painful. Some people do swimming if they have a lot of arthritis. It's not so tough on the knees, for example, compared to walking or other exercises.
Is there a way, Dr. Turner, working with Medicare CMC, so you can work with them because they are the ones who look at the aging 65 plus in healthcare and health insurance? Would it be able to work with them so you can have access to that population somehow to give the information in terms of clinical trials and what they need to do?
Yeah. Unfortunately, our healthcare system just sort of, waits until you have a disease and then you get treatment, and then the health insurers reimburse for that evaluation or treatment. Not particularly strong in preventive measures, particularly when it comes to financing and reimbursing. So, our healthcare system is not really well designed to focus and reimburse for these preventive strategies.
There is another question here that came to me by accident. The question is, are there any comorbidities that would exclude one from a clinical trial?
Yes, there are. Our ideal clinical trial patient is someone who has no other diseases and takes no other medications. And of course, this person doesn't exist. So of course, our patients have other disorders and take other medications. But the things that we cannot have as part of our study, for example, a lot of our studies require MRI scans. And so if you have a pacemaker, you have metal in your body and you really shouldn't get MRI scans, or it's difficult to get an MRI scan. So people who have pacemakers, for example, are probably excluded from most or all of our research. And if a study requires a spinal tap, for example, we wouldn't want anyone on blood thinners because there may be a bleeding risk from having a spinal tap. So if you're on a blood thinner, then you would qualify for a study that has spinal tap. We do require patients to be medically stable, usually cancer-free for 5 years. And all of our studies require having what we call a study partner. So it's not just you that's signing up for a study, but someone else who knows you well.
Right.
Ideally, someone who lives with you, so that
Very
we
good.
can, we can ask questions about how you're doing at home as far as your memory and functioning. So if you don't have a study partner, then you may not qualify, for our clinical trials. But those are the big exclusions, having other disorders, other diseases, being unstable medically, having cancer in the recent past, having a pacemaker, being on anticoagulants. These are some of the reasons that you may not qualify for a clinical research study.
Amina?
There's one more question that came through, and it says, can you enroll people in trials remotely?
We're trying to do more remotely, virtually, as much as we can because of the pandemic. So we have made some components of the research remote, but obviously some of this cannot be remote, has to be done in person. And obviously things like MRI scans and PET scans and spinal taps cannot be done remotely. Blood draws can't be done remotely. But some of our treatment trials are using visiting home nurses, for example. So if you need an IV infusion of an antibody every month, some of the study would be done in the clinical research unit at the Georgetown Hospital. And but some of the monthly treatments could be administered by a visiting home nurse who takes the medication, starts the IV, infuses the medication, takes an hour or two. And so, we're trying to incorporate some virtual steps as much as we can, and trying to incorporate visiting home nurse if we can, to make the study easier to get through for people so that we can get more people joining studies.
Great.
So they usually have a lot of pre-screening, so the screening can be done remotely to see if they can,
Right.
Inclusion criteria.
Yeah, absolutely. Yes.
Wonderful. Well, I want to just thank you both, Dr. Hurtado and Dr. Turner, for such an amazing presentation tonight. I hope everybody found it to be educational and interesting. And for those of you who are interested in learning more about research trials and different research studies, these are some resources that you can visit. You can go to researchmatch.org, where people, can go to find different studies that are available and screen whether or not that's something that you'll be interested in participating in. And we also have our site, wepartnerforresearch.org. So you're welcome to go in there and learn more about different studies available.
May I ask him a question about tinnitus and Alzheimer's?
Yep.
I think we could, yeah, definitely. We have a few more minutes we can spare, yeah.
Yes. I've read that it's not in the ear, it's on the brain, but it does cause Alzheimer's and dementia.
Tinnitus does not cause Alzheimer's or dementia, but it's often an association, but it's totally independent from Alzheimer's and dementia. Sometimes tinnitus is associated with hearing loss, and we recommend getting hearing evaluations and hearing aids if needed. But tinnitus does not cause Alzheimer's.
Okay.
Thank you so much, Dr. Turner. And just so that we can continue on, we have a minute left here. And so we just want to, let everybody know about our participant advisory board. We are seeking new members here, and this is a group of individuals who come together to provide feedback to all of various of our principal investigators. And this is a way to ensure community inclusion into our research studies. And so for more frequently asked questions, this is our site that you can visit. So we will be putting this in the chat so you can go ahead and learn more about all the different questions that come through our different presentations on research studies. And last but not least, we are sending you a link so that you can complete our survey. Your feedback is very much appreciated as we utilize it to come up with new topics that are of interest to our community. And again, we want to thank Dr. Otado and Dr. Turner and everyone who works so hard and works hard every month to bring this together. Dr. Fishbein, who's joining us as per usual tonight, and the whole team that puts this together. And we want to invite everyone to join us next month. Our conversation will be on HIV and for World AIDS Day. So we'll be sending information for everyone so that you have that again, join into the conversation. And the conversation will be December 14, which is just a few weeks from today. So again, thanks everyone. I hope everybody enjoys your evening. This recording and information will be available on our GATS website for you to access at a later time, should you wish to do so.